অফিস কই? আলামিন,
গুড ইভিনিং।
আলামিন তোমার এটা
টপিকটা দিয়ে দাও, টপিকটা দিয়ে দাও।
আলামিন টপিকসটা বলো। অ্যাস্থেটিক প্রবলেম
আমার
সলভ
টপিকটা কি স্ক্রিনে দেখা যাচ্ছে?
ওকে, হ্যাঁ
দেখা
স্ক্রিন
যাচ্ছে।
দেখা যাচ্ছে। অ্যাস্থেটিক প্রবলেম সলভ প্রস্থেটিক্যালি। ওকে ওকে।
ওকে স্যার।
সবাইকে
So sir, I am going to share my topic. Hello sir.
ওকে আলামিন, তুমি শুরু করার আগে আমি একটু বলে দিই, আমাদের ডেন্টাল স্কুল বন্ড আয়োজিত আজকের এই ওয়েবিনার সেমিনারে আমাদের আজকে স্পিকার ডক্টর আলামিন রাসেল, এমএস বিডিএস এমএস, রেজিস্ট্রার প্রস্থোডন্টিক ডিপার্টমেন্ট, ঢাকা ডেন্টাল কলেজ। আমাদের সাথে আছে এক্সপার্ট হিসাবে আছে নাফিস বিন জামেদ, অনুপম পোদ্দার, শ্যাম কে মহারজান ফ্রম নেপাল, নাফিস জামেদ ফ্রম মালয়েশিয়া, আরো আমাদের কয়েকজন এক্সপার্ট আসবেন। এই ফাঁকে আমি আশিক আছে, আশিকুল ওয়াদুদ আছে। তো আমরা আজকের টপিক অ্যাস্থেটিক্যাল প্রবলেম সলভ বাই প্রস্থেটিক্যালি। অ্যাস্থেটিক প্রবলেম সলভ বাই প্রস্থেটিক্যালি। প্রস্থেটিকের মাধ্যমে অ্যাস্থেটিক প্রবলেমগুলো সলভ করা হয়। বিশদভাবে আজকে আলোচনা করবে আমাদের এবং এই প্রেজেন্টেশন নিয়ে আসছে ডক্টর আলামিন রাসেল। আমি ডক্টর আলামিন রাসেলকে অনুরোধ করব তার প্রেজেন্টেশনটা শুরু করে দেওয়ার জন্য। ডক্টর আলামিন রাসেল।
Thank you sir. Thank you for giving me the permission for the presentation. First of all, I want to thank the Basic Dental School for giving me the opportunity for the presentation. Dr. Anupam sir, Riyad sir, and my mentor, Dr. Nafis, and the expert panelist, Dr. Sham and Ashik. So, I'm going to start my presentation. First, I want welcome to my scientific seminar. I am Dr. Alamin Sarkar, dental surgeon, Prosthodontic Department, Dhaka Dental College Hospital. Today, my topic is aesthetic problem for prosthetically in ocular prosthetic. Introduction. Ocular prosthesis is a process where an eye can be replaced artificially to maintain the aesthetics after enucleation and evaluation of eye. It is a teamwork between the surgeon and the prosthodontist. And the ocular prosthesis is under maxillofacial prosthodontics. First, I am going to do the history of the ocular prosthesis. It's first shown in the Iran, 2900 BC. It was made by bitumen paste and covered by the gold. Where we can use the ocular prosthesis, it is used in the loss of eye due to trauma, tumor, and infection. Where the surgical procedure is enucleation, evisceration, and excitation. Enucleation, where the globe and attached portion of the optic nerve are excised from the orbit, and evisceration, removal of the content of the globe while the leaving the sclera and scapular muscle intact. And excitation, a radical procedure where eye adnexa and the part of the bony orbit need to removal. I prefer custom-made prosthesis over the ready-made prosthesis because custom-made eye prosthesis is more precise than the stock eye prosthesis. Unique color matching and patient with the patient adjacent eye, well adaptation and retention, and comfort to the patient. Here a scientific paper published where told that the custom-made acrylic resin ocular prosthesis achieve intimate contact with the tissue bed, and the close adaptation of custom-made ocular prosthesis tends to distribute the pressure more equally as compared to prefabricated ocular prosthesis. Material that need to make the ocular prosthesis, that is regular body silicone, methyl methacrylate resin, watercolor, acrylic color, improved stone, wax, dye stone, and flux. At the procedure, first we have to take the impression of the um, missing eye and cast code, then make the fabrication conformer and then determination the iris size and position in the conformer. Then the iris button and sclera, and then painting the iris and sclera of the patient healthy eye, and trying then trying the color, and then the laminate the iris and sclera with clear acrylic resin, and finishing and polishing. Then insertion. Here I am going to present a case regarding ocular prosthesis. This is the case 1. Here the patient has loss of eye. Here the conformer of the patient after taking impression, and Casper then make the conformer, and here the conformer in the flex, and the painting of the iris, and drying. Here the processes after finishing and polishing. I'm working with the patient in the hospital. Uh, this place is University Saint Malaysia, where I work of this patient. My mentor is Dr. Nafis. Here the processes after insertion, and my mentor and the happy patient. And the case 2. This is the another case where the lady lost her eye, and this is the impression tray. And after taking the impression and making the conformer, and iris position and size is determined into the conformer, and then the iris painting and shade drying with natural eye. This is the final processes after insertion. Here a video regarding the processes is moving around and in the socket. looking almost natural. Uh, Conclusion. Uh, can we make an artificial eye which can we see? The answer is no, but we can think forward. Thank you all.
Please unmute. Adi sir, please unmute. Please unmute.
Sir,
Okay.
Okay, sir. Okay.
Thank you, Dr. Alamin Russell, for your nice presentation about ocular prosthesis. We know the maxillofacial prosthesis is an intraoral prosthesis and extraoral prosthesis. In extraoral prosthesis, ocular prosthesis, ear prosthesis, and nose prosthesis, you presented some cases you have done of ocular prosthesis. Here, every steps of prosthesis, that is impression, model preparation, and already you have prepared, and finally eyeball and iris and all lost structures or lost anatomy of the ocular cavity you rehabilitated. It's a nice one. Now I like to invite panelists to discuss and to or to ask to the question, or some they discuss about some wanting to Dr. Alamin Russell's. Okay, first of all, on Dr. Ashikul Adut, you speak some words, some about the his presentation.
Thank you, sir. Dr. Alamin, you did a good job. As because it's a very specific subject in maxillofacial prosthodontics. First thing, in Bangladesh, it's not established that much. So we have to go in some training courses in abroad, and we have to learn from there. But we have to try to establish these things in Bangladesh. And your case is done well. I think the first case is a little bit easier than the second case, because second case have some ptosis. So ptosis correction is very challenging for ocularist, and I think Nafiz guide you are very wellly, and that's why you did it very good job there. And also we have to enrich ourselves, and I am requesting last time also, and I'm requesting again, Professor Ajit sir, to help us to establish this maxillofacial prosthodontics field in Bangladesh. The one thing is, like, for discussion, actually you are showing only one type of ocular fabrication process. That's because of, like, the Irish fabrication is like the painting technique. So we have I think 2 or 3 other also other steps. So it's if it's possible, I will ask Dr. Nafiz if he has prepared something that he can show us the other techniques to fabricate of Irish in other steps. And this is the one of the steps, I think, the painting technique. But we are using some other technique. We have also like a handmade technique. There is also like the from Mahidol University techniques, because this is their techniques. We cannot show it to all, but we can little bit discuss about that if Nafiz is helping us. And another one is button iris technique. So we can also ask. I'm also asking Nafiz to show or discuss about this technique during this time. Thank you.
Thank you, Dr. Ashikul Adut. now I invite to speak some about this presentation and some discussion about these topics. To Dr. Syam K. Mahajan uh, from Nepal.
Hello, sir. Okay, it was a really nice presentation by Dr. Amin, and maybe Dr. Nafiz should be much more happier because he guided Dr. Amin for the fabrication of this maxillofacial prosthesis, and I hope the patient must be very happy with the prosthesis and can have more quality of life. Uh, uh, he has explained everything, every steps properly regarding the ocular prosthesis fabrication, and it's always a challenge. Actually, it is always a challenge to all, especially in a developing country like Nepal, and maybe same thing maybe in the Bangladesh too, to get started with such type of cases. I'm also very I would like to say that I'm very lucky that I could learn some more thing from my professor regarding this maxillofacial prosthesis. Even in my earlier present, I mentioned that Professor Suraj, he guided us a lot for the fabrication of this maxillofacial prosthesis, and he's also known as the person dentist who used to make eyes, and he's also from the Dhaka Dental College. Now we have learned few, and as Dr. Anupam requests me to show a few things how we do these ocular prosthesis here in Nepal. So if I get the permission to share my screen, Dr. Anupam, can I share my screen, and so that we can discuss a little bit regarding
Yes.
ocular prosthesis?
Yes, you can share your
Okay.
screen.
Okay, sir. Thank you, sir. And maybe Dr. Nafiz, maybe he can help and guide us more regarding this fabrication of the ocular prosthesis.
Okay, thank you, Dr. Syam K. Mahajan. Now I want to go to Dr. Nafis, who were a mentor of Dr. Alamin Russell. Dr. Nafis was a mentor of Dr. Alamin Russell. We want to know elaborately.
Ajit sir, please.
Also,
Ajit sir, Dr.
Please.
Shamke Mahajan shows some slide. Dr. Shamke Mahajan shows some slide. He get permission from
slide.
you. Yes.
Oh, sorry. Actually, I was wrong that the speeches of Dr. Syam is not yet finished. He will show some slides, and this super specialty of ocular prosthesis, I like to know so from him about the slide in which this technique or steps will be elaborately discussed. Okay, Dr. Siam, please start.
Okay,
Would you like?
thank you, Ajit sir. Okay, I have prepared this in a very less time. Okay, so I hope I will able to show how we do these ocular prosthesis in our scenario. Okay, sir. So, okay, we have already, Dr. Amin has already discussed about the conditions, like we can get the case of eviscerations, and we can get the condition like enucleation, as well as we can get the condition like exenterations for these different ocular or the orbital defect. So, for the ocular rehabilitation with the ocular prosthesis, maybe uh, uh, we may be available with the stock high. So it will be the most easiest way, but in many cases it will not fit properly because every case will be different, and the color matching and the fit of the prosthesis will be difficult with this stock eye. And next will be the customized ocular prosthesis, and these customized ocular prosthesis looks more better than the stock eye. Okay, and the fit and even the mobility will be better in those conditions. Maybe in some conditions, if the eyeball are intact, maybe we can have or we have the very less space, we can only have the ocular shell also. So these maybe the different three type of ocular prosthesis we might encounter, we usually place for the patient. So these are the advantages of these custom ocular prosthesis. Dr. Amin has already discussed regarding this also. So it will help to improve the adaptation to the underlying tissue, and of course there will be the increased mobility of the prosthesis, and it will enhance the facial aesthetics and even the facial contours. So to go with the different steps, okay, so first we need to examine the patient and evaluate the ocular defect. So we have to see for the proper healing, if there is proper healing or not, we have to evaluate that. And we have to evaluate for the presence of any contractures in those areas. And if the patients are the previous prosthesis wearer, we should look for the irritation caused because of those prostheses. And we have to also evaluate the muscle control for the mobility. Okay, so has to get the proper mobility of the prosthesis, and also we have to evaluate the depth of the furnaces, like it's like a sulcus where we can extend the prosthesis, and it will be more retained if the depth of furnaces are better. So for the impression, if we have these type of ready-made tray, it is always better and it is easy for us to go with the impression. We'll check the fit, we do the tray selection, and we'll go for the impression making procedures. Like we can use the light body, so we can just inject some light body in the defect area. Okay, then we can place those tray or conformers, and we can make the very good impressions of those ocular defect. Okay, if those tray are not available, we can fabricate the custom tray also. Like we can just inject the alginate with the syringe in the defect, so as to get the impression, okay, of those defect, where we can use the self-care acrylic. So here the self-care acrylic is used to fabricate the custom tray like this. These are the steps. So in those control or trays, these trays are may not be easily available in every place. So this method, maybe I hope this method can help a lot. Okay, if we want to start with this ocular prosthesis. So with the help of the alginate impression, we can just fabricate the custom tray. Okay, so this will be the final custom tray, and this syringe uh, will help us to carry the impression material. So here later on we can just mix the light body, or we can attach with this auto mix light body also, or we can just mix the light body and we can just inject that through this syringe also. So so that we'll have the impression of those defects. So this may also help a lot. Then we need to fabricate the wax model, so wax pattern for this prosthesis. So just for that, we can just invest this impression in the alginate. So this is how we invest this impression in the alginate, so that we can achieve the wax pattern. So this is the finished wax pattern of the ocular prosthesis. Okay. Then we need to train this wax pattern. So this is the photo where we am showing the trial of the wax pattern. So wax pattern will be inserted in the defect. Okay, and then we just evaluate for the fullness and support of the this eyelid and the bulkiness of the eyeball, so that it will look more, it gave the more pleasant appearance. Next will be the orientation of the iris or centration of the prosthesis. So there are a lot of methods we can follow for this, and simple is we can use this divider, so that will be easily available. So from the this corner of the eye to the iris, we can just measure the distance, and just we can transfer this into the wax pattern. So as we can subscribe a circle for the iris. So we can measure the we can just position the iris with this method, and then we can just attach the iris button. So here we can also place the iris button, and we can just check the orientation of the prosthesis with the help of this iris button. Next will be the processing. We can go with the investment of this wax pattern. Okay. And regarding the this iris, okay, regarding the iris fabrication, there are the different methods. So this may be the one of the better method, and it also show the depth of the iris. We can just incorporate the depth also with this procedure. So after we do the dewaxing, okay, just we can get this iris button, and just we can wrap with the this tin foil, okay, and we can place that back into the investment, and we do the processing, okay, and we do the processing, and we will get the acrylic sclera blank like this, okay, sclera blank like this, where we can just remove this iris button, and the tin foil, it will help as a separating media, so that we can have the proper depth of the this iris will be embedded in this sclera blank. Then we can go for the trial of this sclera blank. So we can just do the trial, and we can just evaluate the aesthetic of the patient with this sclera blank. Then even the previous moderators expert, he explained the different method, and this is the this is also the one method where we do the painting. We can use the acrylic paint and just we can do the painting, and we can do some characterization with this plain acrylic. So then we'll go with the processing. Then we'll go with the processing and with the clear acrylic. So this clear acrylic will be there as a laminate, and it will just protect the whole sclera. Okay, so this is how we can fabricate the prosthesis. There are the different method, like so this is the final prosthesis what we achieved. Okay, so there are the different methods to have those iris. Okay, so we can use the stock eye also. We can use the stock eye. Okay, so while doing the trial, we can just subscribe the position, actual this position of the sclera. Okay, and we can use this stock eye. We can just trim out this iris, and we can just trim out this iris, and this is the final trial prosthesis where the iris is obtained from the stock eye. So it can also be done, or we can have this if we can also have the commercial available iris button where there are the different size of the iris with the different colors. So these are also available. And next we can do the painting. So Dr. Amin has shown clearly that how we can do the painting of this iris button to fabricate the iris. So different method can be followed to prepare the iris. So this video will show the mobility of the ocular prosthesis. So this is the ocular prosthesis here patient have. So we can have the good mobility can be seen with the prosthesis, customized prosthesis also. So we can go with this case presentation. So if we have the ocular defect, as I have previously mentioned, we can take the impression with the alginate. Alginate can be used to prepare the our preliminary impression, where we can fabricate the this customized tray for the patient. And in this, we can use the light body. We can just mix the light body, and we can have the final impression. So final impression can be achieved. Then we can do the investment. Just we can invest that in this alginate, and we can pour the this mold with the modeling wax. So so this is the pattern that is shown in the investment, and it can be finished. Okay, then it can be trial in the patient. So it can be tried in the patient, and the iris is oriented. So this is the iris button. We check for the orientation of the iris. Okay, then we go with the processing, the way similar to the way which I shown before. So here we can have some depth. So but few things should be we should be clear with a few things, like we should have a bit smaller diameter of the iris, like 0.5 to 1 meter smaller than the actual size of the iris, because once we do the painting and we laminate this with the clear acrylic, because of the bulk of the acrylic, some magnification will be there. So we'll have the depth. We can see the depth with the proper iris. Okay, so that should be kept in mind prior. Okay, so this sclera blank is tried, and as I previously mentioned, we just do the painting with the acrylic paint can be used with the help of the monopoly. So pen acrylic were embedded there, and finally it was laminated with the clear acrylic. So this is the final prosthesis. Okay, so once the patient wear the specs, so it will be not so much prominent. Okay, so it will clearly help to mask the patient defect, and aesthetically patient will looks more better. So this is how we can fabricate the this ocular prosthesis. So I hope like I have shown few alternative methods that can be used for the fabrication of the ocular prosthesis. So this ends my slides. Okay, so if any queries like you can just ask me also. So it's not like a presentation, but actually just I like to discuss the different technique, the way how we are doing, we are fabricating these ocular prostheses. Okay? And beside this, there are the different technique can be used. Like if we are devoid of this stock eye, or we have not so good skill of doing the painting, even we can just print the actual size of the iris. Okay, we can we can have the many articles where the iris has been printed, and that was attached on this sclera acrylic sclera blank. So there are the many alternatives, or the many ways we can fabricate the prosthesis. Okay, Anupam sir.
Okay, thank
I
you. Thank you, Dr. Siam, for your nice slide showing and discussion. You asked to ask some questions. Here is my question. I want to ask you one question.
okay, sir.
In your slideshow, the sclera is resembling the natural. How can achieve this? That is, I think these veins are is shown in the sclera, artificial sclera. There is a artistic way in which resembling like a natural. How can achieve these natural things, natural picture, natural scene?
So like we have different type of tooth color acrylic are available. So the basic shade of the sclera that we can match with our shade guide, and we can use the proper color, tooth color acrylic. Okay, one first step is the selection of the proper tooth color acrylic that resembles the sclera. Okay, and to resemble those veins, we can we have the vein denture based material. Okay, the denture based materials are available in the vein and the plain one. So we just filter we just filter those vein from the denser based acrylic, and we just embed those in acrylic vein uh, in the prosthesis. And for different some like sclera will be not so clear, there will be some tint will be there. For that we can use the acrylic color.
Thank you, Dr. Siam, for your nice discussion and answer of my question. Now, I want to go to Dr. Nafis, who was a mentor of Dr. Alamin, that is in Malaysia, where did his training, that is Alamin. Alamin asked one question, that is, Dr. Ashikul Adut raised a question, that is there are only a few maxillofacial prosthodontists in our country. Actually, this super specialty of prosthodontics is neglected. Only few prosthodontists, maxillofacial prosthodontists are working in Bangladesh. We want to give training about this type of this maxillofacial prosthesis, but those who are actually the Ashikul Adud, Saiful and Nafis in Malaysia, you are the pioneer about this super specialty. So you can start to give the students the start to give the training who are interested, and such a way I think this specialty will be in a advancement of this type of super specialty. So I think you will be come up about to give training. So now I want to go to Nafiz Ahmed about I want to know some and elaborately steps, techniques, and other everythings about this type of ocular prosthesis. Okay, Dr. Nafis bin Jamaat.
Thank you, sir. Assalamu alaikum. And it's almost midnight at Malaysia. Right now we are 1 a.m. and in Bangladesh it's also going to be the midnight. So that was a very fantastic presentation by Dr. Alamin Sarkar, and last but not the least, Dr. Sham Marjan. We have already covered many things like basic steps of fabrication of eye prosthesis. Also, we have covered some of the scenarios where we can actually approach to rehabilitate those defects in order to make with the ocular prosthesis. I will not talk about those things. I just want to add up some of the things. First thing is that maybe I will try to share my screen. I do not know because my internet is very poor, but I would try. Basically, what is actually the objective of fabrication of eye prosthesis? We actually did publication of one paper, which I would like to show about this one. We did a research on European that was been published at European Journal of Dentistry. So this paper talked about a comparative assessment of prosthetic outcome on enucleation and evisceration in 3 different etiological eye defects. So if we could see very sincerely this scientific paper, because right now we talked about just cases. Now I'm more focusing on the research, what actually the clinical research is saying to us in the current days. So what are the keywords here? What are the keywords? Prosthetic outcome. This is the first keyword. Second is enucleation and evisceration. Dr. Ashikul Wadud will agree with me. When we were at Mahidol University in our time of training, we were not into that position in order to learn how to do coloration and how to make prosthesis first. We have been taught what are the basic etiologies of eye defects. If you really want to make a very nice eye prosthesis, now the question is, how could you say a prosthesis is nice? The prosthesis has to be aesthetic. Also, at the same time, prosthesis need to be functional. Now, if you make a very nice prosthesis, looks very beautiful, absolutely beautiful, it match your color, right? But the prosthesis doesn't function. You know, your prosthesis will fail. Now the question is, will the patient could see vision with the prosthesis? Definitely no. But then what is the point of saying the prosthesis can function? Actually, this terminology lies within this paper, if you could read this paper. So how a prosthesis can function? we have to understand Newton's third law. Every action has an opposite and equal reaction. Similarly, when we lose a body structure from our face or any part, right, what will happen? Slowly, the body supporting structure would collapse. So if I miss one of the eye due to any defect, maybe congenital, but mostly the acquired defect like road traffic accident, cancer and other things, what will happen? The surrounding structure, periorbital bone and bone rims, surrounding orbital pad of fat, I mean to talk about the surrounding supporting anatomy. Those anatomy would collapse. If the anatomy would collapse, what would be happening? Your face will develop some sort of asymmetry. Right. Now, if your facial structure is become more towards asymmetry in fashion and already have developed asymmetry, then how beautiful prosthesis you would make, it will not come as a complete result that you want as a prosthodontist. So we wrote this paper, which was talked about a comparative assessment of prosthetic outcome of enucleation and evisceration. So basically, if you see this paper, I want to just show the same case in the slide, if you could see that, okay. So this patient had a right eye acquired defect. The cause was squamous cell carcinoma. So after diagnosis of this tumor, what type of surgery was done? Enucleation. For ocularists, for us who are maxillofacial prosthodontists, our first matter which we think for the cases are, what was the cause that eye has to remove, number one, and what type of surgery was performed. These two are the most crucial. We do not jump into any case to make a prosthesis. So because of the enucleation, you see that patient has developed some sort of a situation which we call post-enucleation socket syndrome. What do you mean by post-enucleation socket syndrome? There are several conditions which may define a post-enucleation socket syndrome. If your eyelid is so much damaged that you cannot control your eyelid in order to open and close, and you try to open the eyelid, but you do not have that much of control that how much you want to lift up the eyelid. So there is a limitation of movement of the eyelid. The intra and extraocular muscle already have lost the power because of the enucleation. Because in the enucleation, surgeon removed the eye globe, but also removed some portion of the extra and intraocular muscles and the nerve endings. Now, in this case, if you do not understand what would be the impact of enucleation, how much and how beautiful prosthesis you are making, it does not work. So we have to understand before making or before jumping into making prosthesis, what happened to that patient, number one, and what type of surgery was being done onto that patient. We have to remember, as a maxillofacial prosthodontist, when we make an ocular prosthesis, we are not making a prosthesis for a doll. We are making a prosthesis for a human subject. So we have to take care for the orbital cavity, but at the same time, a proper ocularist or maxillofacial prosthodontist also take care of the surrounding structure, like upper eyelid, lower eyelid, upper sulcus deformity, upper conjunctiva, lower conjunctiva. So all those things we have to take care with the eye prosthesis. So we make the prosthesis, and I'm very sorry to say we had an agreement with the Mahidol University. We cannot show in general Facebook how we make, because the technique that we learned from Mahidol University is the same technique, is the copyright by the MD Anderson and Sloan Kettering Center from the USA. So we could not show step by step on that. But yes, you are most welcome at Malaysia in our center in order to learn that advanced technique which Dr. Alamin had with me, but it was very short training. It was a training about like only 4 to 5 working days. So after making these prostheses, if you see the before, so you notice that this is the scenario. Patient could not lift up the eye, and the eyelid muscle power is very limited. But after having several series of processes of giving therapy, we give a therapy, right? This, which is called conformer therapy. The outcome is something like this, which is very natural. Basically, in our technique, we do not focus on coloring. We focus on taking care of the surrounding orbital cavity. It is exactly same with the implant. Placing implant doesn't matter. The beauty is how you control the peri-implant pericoronal tissue, right? We have to deal with the gingival line, with the pericoronal and the neck of the implant. It is actually the same. We do not emphasize or do not give too much stress on the colorations. We give more stress in order to maintain the integrity of the surrounding structure. This is the thing. Second case, I go a little bit faster. If you notice this case, patient had a severe trauma and patient lost many structure, orbital pad of fat and muscles at the superior sulcus. This case is defined as a superior sulcus deepening. Most of our cases in our practice, either we have ptosis or we have superior sulcus deformity. Now, if I do not care ptosis, if I do not care superior sulcus deformity, and I'm only focusing on giving just a prosthesis, the oculoplastic surgeon, the eye surgeon will kill us because we are going to damage their socket. And many researches has been published and it has already been sealed by published articles. They said that we need to take care of the surrounding orbital cavity. We should not focus at the first line just to make a very color to color match. No, that is not the first objective. The first objective should be the second and third. The first objective should be to maintain the integrity of the supporting structure, number one. Second should be the color and aesthetics. This is number two. So what happened after several series of prostheses? The prostheses look like that. You see that with our prostheses, we took care of these defects, superior sulcus deformity. There's a big defect. Now, if I made a prosthesis which looks exactly same as the right contralateral eye, but I could not improve this defect, the interfacial symmetry would not have been improved. So that is the main objective that I supposed to say that a beauty of custom-made ocular prosthesis is that it does not only rehabilitate, it does not only make a prosthesis which is exactly the same color with the contralateral eye, but also it rehabilitates. It recapture the surrounding orbital structure which was being affected due to this enucleation or evisceration, the type of surgery or the type of defect. So that was about the thing. So if you look back to this paper, we had a case 1 and case 2. We published this one. So we used several series of conformer. And after using of this conformer, we proceeded to the colorations. So outcome was something like that. So we have also few more cases. I'd like to make it more larger if you notice that. Okay. I hope you guys can see. So if this lady, if you can see that there is a big void of defect, right? So this is because of the evisceration. Now, evisceration is a more aggressive type of surgery. In that surgery, not only the eye globe, but also the more surrounding structures of the orbital cavity has to remove it. So patient usually develop a big socket sort of defect. But we rehabilitate it with the eye prosthesis. It looks more natural. But if you see these cases, right, patient internally has lost the ability to open the eyelid. Now, in this case, if you make a very nice, beautiful prosthesis, but with your prosthesis, patient could not lift up the eyelid, then how could you project the beauty and aestheticness of your prosthesis? This is quite, unacceptable. So we need to take care of the eyelid first. So we use several series of conformer. We added wax, and we give several series of therapy, like 3 to 4 months, and we after that, patient could lift up the eyelids, so it is become more visible. So so if you see that this part, So if you compare the left and right, it's quite, I would not say that this is 100%, but I would say that this is 70 to 80%. So summary of my this paper is, yes, we believe that we need to make a very nice prosthesis which has to be very color matched and color blended, but we should not forget the surrounding periorbital structure. So that is the part was missing. So I just wanted to add. I would like to share some of the coloration thing, if you allow me to do so. Just a second. Okay. Usually, in our case, because this is the video that I will show now. This is for the point of interest for the general people interest, because many people over the period of time, they've been asking us that, doctor, we see the prosthesis, but we want to see that how you do the coloration. So this is not for a very academic purpose. This is just to share how we do the coloration. So later when this video would have more views, people can see that. So usually we okay, so usually we color like this, that you can see that. Okay, just to make it a larger screen. Give me a second. Okay. So you can see that this is the prosthesis. This is already Dr. Chan has discussed how to reach until this. I'm just talking about the colorations. Usually we use the basic color. We have to go back to the old school, like blue, yellow, and red. If you notice that, so we are putting blue, yellow, and slowly we are putting more color like red. So red will be coming here now. So this is red, right? So these are the basic color. Now, I usually teach my daughter, like, if I ask you that, if I mix blue with the yellow, what is the color? It will be violet. If I mix yellow with red, what would be the color? It's like orange. So those are the secondary color. So we use actually the basic coloration to do the coloration. And we can use some brown in order to match the shade, and then we use the something like this. Once we have that one, go to the next video. Just a second, because there are several video here. Okay. I think, okay, so this one. Okay, so then you start mixing the color, right? So as I said, that when you mix like red with yellow, you get like orange sort of thing. When you mix a blue with yellow, you get a violet, and you have these kind of shades. So you slowly start the basic color integration into the sclera. So when you do the this is a picture that we are showing, that how we do the, if you look at our eye sclera, there are many vessels, right? So some people, they use a thread, different kinds of threads from the cloths. They can extract and they can implement there. So this is like after painting, we just put the sclera. Actually, I'm not prepared. I have like, if I had a time, I would have prepared like sequentially. I'm so much sorry that I'm presenting totally unprepared. So this is a picture of how we do the integration of the blood vessels. Also, I have more video. I just show one by one. That is all about how you integrate the okay. Just a second. We have, okay. So this is another video, how we apply the color. So this is the video that Ashikul was saying at the beginning of the presentation, that how we do the the Irish button, like clockwise or anti-clockwise, one direction. So this is the Irish painting. We have another technique in Mahidol we used to stitch. But this is a very commonly used technique. That's how it looks like. You see that. You just paint. So that is like a button sort of thing. This is like some of the cases, if you want to make more specific according to the patient color. And what else I have here? Okay, let me see this one. One more video. So if you notice that after doing the coloration, it looks very glossy here. What does it mean? Because one of the problem is that once we do the coloration and when we pack the clear acrylic from the above and bottom, there is a tendency to dislodge the color because we are packing. So in order to prevent that, we have a kind of sealer we paint over the prosthesis. So what would happen that we after painted of that one, we keep that one aside and we wait for the whole day. Let it become set. After one day, we do the packing. So what is the benefit of doing that one is your color is being set properly. It is integrated into the scleral shell. So later part of the day or the very next day, when you be packing the upper and lower acrylic part, the color, because of the pressure of the clamp, the color would not dislodge. Something like this. So this is more about the aesthetic colorations that I would like to share. So going back to our discussions that I just summarized, because today I'm not that much of prepared with my presentation. I wanted to just add one thing that we should not jump with any ocular prosthesis just with the coloration. This is number one, because research has said that we should focus on the periorbital socket first, because post-enucleation socket syndrome, any eye when it has been removed, they have a situation called post-enucleation socket syndrome. We need to take care of the post-enucleation socket syndrome first. After taking care of the post-enucleation socket syndrome, then we can focus on the coloration and aestheticness. So the prosthesis, if we do like that, the prosthesis would be in one side aesthetics, and in another side it would be functional. Because many of us doesn't know that prosthesis may also act as a functional component, but many of us believe that the prosthesis is only for the aesthetics, which is very much wrong. Prosthesis should act at the first line as a functional. It should maintain the symmetricalness of the facial structure. This should be very important. It should maintain the post-enucleation socket syndrome consequence. Then, once it maintained that by improving the eyelid, by improving the ptosis, by improving the superior sulcus deformity, lower eyelid sagness, and all those things, then the prosthesis would go for the color and aestheticness. And regarding the aesthetics colorations, I think most of us focus, and many of us in the world, they have many different techniques, right? All the techniques are highly successful. Research has shown that none of the technique is like not a significant difference in terms of successness, right? But in order to maintain the integrity of the surrounding structure, has a significant role in order to, how should I say it, that in order to successfully rehabilitate any ocular defect. That's all. Thank you very much.
Thank you, Dr. Nafis bin Jamet, for your nice discussion and elaborately have discussed it. Thank you again. Actually, you told these things, that is the process is not only the aesthetic, it should be functioning. It should be functioning. And a good aesthetic ocular prosthesis depends upon the surgery, deformity, and some other factors. You told this, and other some discussions. It was nice. Actually, you are engaged to do so many ocular prostheses, and you are the prosthodontist, maxillofacial prosthodontist working in Malaysia, and you are a teacher, you are a mentor, you are a trainer. So thank you, Dr. Nafis. I think Dr. Riyadh is in sin. So I want to send my moderator speech and moderator functions to Dr. Riyadh, and I request him to continue the next part of this seminar.
Sir, yes, sir.
Dr. Riyadh.
Thank you, sir. This is a brilliant performance, excellent performance by Nafis and also Mohammad Alamin, and very good performance. Though, pardon, please, I have some sort of work and today I joined late. Sorry, pardon, please. Thank you, sir. I'll continue next session. And this brilliant performance, actually, we did some ocular prosthesis in our graduate post graduation. Russell was with us, but what Nafis showed, that was tremendously brilliant. And I think nowadays we just buy some ocular prosthesis from the Aziz market nearby our BSMMU and put it there. But there are a lot of problems regarding that preform eye prosthesis. It's especially made up of glasses, and sometimes it doesn't fit in the eye. They comes, and eye department also comes, and it will be a great window if we please elaborate. Nowadays, dentistry is not dentistry only; it's all around the face, and reconstruction is a uh, very upcoming situation. After surgery, reconstruction is mandatory, and it should be kept in our mind that reconstruction is very much mandatory, because social rehabilitation is every rehabilitation is needed, functional, social, every rehabilitation. Uh, Thank you, sir. Thank you for giving me a room. Thank you, sir.
Actually, I am requesting Dr. Riyadh to
Sir,
continue the next part of this seminar as a moderator.
sir, though I joined later, it is very tough for me. Is there any question, sir? Is there any question regarding to the ocular prosthesis? I think, sir, can we go to question answer session or all discussion?
Okay, thank you. Thank you. Where is
Okay.
Anupam? I think Anupam. Now, I am requesting Dr. Anupam Poddar for his speech and discussion about today's uh, topics, seminar, and everything, as he is coordinating this type of program continuously. Dr. Anupam Poddar.
Thank you, Dr. Professor Dr. K. Madhvilok, sir, for your nice and wonderful introduction. Uh, First of all, I would like to thank as a coordinator to Professor Dr. K. Madhvilok to take chair as a chairperson of today's webinar, and also thanks to all panelists as well as speaker, and Dr. Shamke Mahardan, the assistant professor in People's Dental College, Malaysia, Dr. Nafis bin Jamaid, medical official postodontist, worked in University of Science, Malaysia, and Dr. Ashikul Wadud, worked as a assistant professor in Abed Dental College, Bangladesh, and Dr. Muhammad Alami Sarkar, who works in Dhaka Dental College, Postodontic Department. He worked many cases like operator and, um, like extraoral prosthesis, like eyeball prosthesis, sector. So I think this is the nice session and brilliant session, and both participants and both panelists and both speakers discuss elaborately and excellently, nicely. I hope all viewers of Bangladesh are very much enjoyed this session. Hopefully, Dr. Nafis bin Jamait next time participate in another webinar for any type of external prosthesis or any type of integral prosthesis. And he will I think he's a brilliant speaker, and everybody enjoy his session. Some due to some unavoidable circumstances, she would not present here as a properly, and I hope next time you will join with us. And Dr. Rajiv Kumar Bonik, finally she comes here, but he is the original moderator of today's webinar, but he comes in later, very, just
Actually,
our session. Okay, thank you, Rajiv, to come here.
Dr.
I'd like
Anupam,
to thank to you, uh, and uh, thank you of all panelists, speaker, and our chairperson. And I'll go to the Dr. Rajiv Kumar Boni for you ending the session as a chairperson of today's session,
Moderator.
Professor Dr. Agim Agzil.
Dr. Anupam
Okay,
da,
thank you, sir.
Dr.
Thank you.
Dr. Anupam, Dr. Anupam da, please can you
Thank you.
hear me?
Thank you, Dr. Anupam Poddar.
Sir, can you
Dr.
hear me, sir?
Rajiv, our moderator, is seen in the in
Sir,
our program.
one
So
thing that
Sir,
Rajiv's daughter birthday today, and he just completed her birthday, Roti's birthday today, and he completed his family work, and now is joining. Thank you, sir.
sir, can you hear me?
okay, Dr. Rajiv, if you want to talk something, Dr. Rajiv.
Okay, sir. Actually, sorry for the late. Dr. Riyad told that today is my elder daughter's birthday. So I was always trying to. After that work, I was trying to enter this session, but due to some network problem, I was unable to go through this session. But I know and I expected always that it was a very excellent session because Dr. Nafis and Russell and Dr. Shan and all those
All
Ashigwadu,
the
all
brilliants
are
are
here.
here. It was a brilliant
All the
performance
brilliants
I
are
have
here,
ever seen.
definitely.
Yes, and this is the favorite topics: ocular prosthesis. Because color
Definitely,
matching, shape
and
matching.
which is as well as very essential for our society.
Yes,
But and we are lacking always. We are lack of this treatment. On trying to achieve this treatment, but due to some, I always say, due to lack of training and due to lack of knowledge, we cannot provide this treatment to our patient. So, sorry, Dr.
Okay,
Anupam has given me the opportunities, but I
special
want to
thanks.
say
Yes.
that at this last, I don't. I want to continue, Dr. Anupam Poddar. Dada, please continue. You can continue this. Thank you, Dada.
okay, okay. Now we can conclude the session. We can conclude the session. So